Ischemic heart diseases caused by inadequate supply of blood and oxygen to the portion of myocardium. Imbalance between myocardial oxygen supply and demand. So when the tissue doesn't get enough oxygen, what they need. Factors that affecting myocardial oxygen delivery, basically they're determined by the coronary flow. And this is what we have on to the myocardium. Myocardial oxygen extraction from the blood is nearly complete, even at rest, so it cannot be increased. Another well-known situation that coronary blood flow is essentially negligible during systole and therefore determined by during the diastole. Perfusion pressure during diastole, aortic diastolic pressure, also influences the coronary circulation. If you do have tachycardia, the time of the diastolic time is decreases. This is why it's less time for the coronary circulation. Plus, the demand of the myocardium is much higher if they work more. Another very important, the cardiovascular resistance that is further influenced by, for example, atherosclerosis, intracoronary thrombi, metabolic products that causes vasodilation or vasoconstriction, autonomic activity, and extracellular compression. The major determinants of the myocardial oxygen consumption is the ventricular wall stress that influenced by both preload at the end diastolic pressure and afterload the end systolic pressure, heart rate, as I mentioned before, iotropic state, contractility, the myocardial metabolism, glucose versus fatty acids. Ischemic heart diseases can be classified based on the clinical symptoms. Not every ischemic heart disease they do have symptoms. There are some that is asymptomatic. Another one, the angina, that is very characteristic pain. Angina, however, can be silent, stable, unstable, and vasoplastic or Prince-Metal it's called. And further, more severe myocardial infarction that can be classified as NSTEMI and STEMI, non-ST elevated myocardial infarction or ST elevated myocardial infarction. And another, the Q and non-QMI, that those today has less and less importance. Angina pectoris is a clinical syndrome usually characterized by episodes or paroxysm of pain or pressure in the anterior chest. The results of the myocardial ischemia caused by an imbalance between myocardial blood supply and oxygen demand. The cause is usually the insufficient coronary blood supply. The severity of the angina is based on the precipitating activity and its effect on the activities of daily living. Some precipitating factors, such as severe anemia, if the blood cannot take enough oxygen, cannot absorb enough oxygen, and not taking enough to the peripheral tissues. Fever, when the temperature increases and the basal metabolic rate is increases. Tachyarrhythmias, by reducing the diastolic time or increases the myocardial demand. Catecholamines, emotional stress, hyperthyroidism that usually works through the myocardial oxygen demand. The type of angina that usually the ischemia that has clinical symptoms and usually that cause the lesions and that is caused by an inadequate blood flow. Silent angina. Silent angina when they are taking ECGs and they do have the typical sign ST depression of angina, but the patient does not have any pain. The stable or effort angina when the pain with stable angina is predictable, occurs with progressive exercise and induced by approximately with the same workloads, usually relieved by rest. Doesn't last longer than about 30 minutes. So the patient when feel this pain, immediately stop whatever they're doing and the pain relieved. Unstable angina is more severe one. Usually it can occur anytime and the frequency or the pain, it's more severe one. It can occur at rest or exercise, so it's not predictable. And herald impending CV event. Contraindication to exercise. So don't force the patient to use exercise. There is another type of angina that calls work through angina, when the patient feels the pain and work more, and the locally increase of the dilator, dilating the coronary and relieve the pain. But it is very, very rare, so don't do this because the patient can have MI. Requires immediate medical attention. This is due to the pathomechanism of unstable angina that we are going to talk about a little bit later. Another type of angina that is vasospastic angina or called premenstrual angina. It has to be differentiated from the real myocardial infarction because this is presented on ECG as an ST elevation that is very similar to the hyperacute MI. Usually this is due to an increased sensitivity of the muscle to the spastic agent, so the spasm of coronary is so severe one that they are altering the blood flow. Stable angina. The stable angina that usually occurs when the patient does have the same amount of work, an effort or work activity, and this is due to a stable coronary plaque that usually narrowing the coronary is more than 70%. And when we do have some exercise, when we do have an increased heart rate, first of all, the diastolic time decreases. This is why with this narrow lumen, less oxygen or less blood can go through, and the increased demand in the periphery that basically cannot be supplied with enough blood. So this is why the patient sensing angina. When they stop doing the exercise or stop doing whatever is induced the pain, heart rate decreases, and the amount of blood that can be pushed through with this narrowing is enough to supply this final portion of the myocardium, and the patient does not sense the pain. Unstable angina, however, is different one because this pain occurs in any time at rest or by exercise, so it cannot be determined, cannot be predicted when it comes. It may be the initial presentation of the ischemic heart diseases, or it may represent the abrupt deterioration of a previously stable angina syndrome. Unstable angina is provoked by easily and persists for longer than stable angina. It may fail to respond to therapy. Pain is often associated with reversible ST segment depression on ECG. The pathomechanism of unstable angina is a plaque or an injury, that is this area when we do have the endothelial layer is disrupted, some thrombocytes is going to aggregate, and these thrombi can be liberated, and a final arteries can be occluded. However, this thrombus is very teeny tiny one, so this is why the normally occurring fibrinolytic activity can dissolve this thrombus, this plug, within 1 hour before the necrosis occurs. But a matter of the time, a matter of the chance, how big this thrombi are, so basically this is the difference between MI. If a bigger plaque is liberated and occludes a larger artery, there is no time to dissolve the plaque by normal fibrinolytic activity, and after 1 or 2 hours, the myocardium is necrotized. So infarction is going to develop when the cell death occurs. And that's a permanent changes. While the unstable angina is temporary because the pain relieved and not happening any kind of necrosis of the tissues. The premenstrual type of angina usually occurs transiently when the coronary blood supply stopped and affecting the large artery. That this patient usually has a very high sensitivity of the contraction, usually affecting the young girls. And When this spasospasm occurs, transmural ischemia develops and a ST segment elevation can occur at rest or with exercise. More prolonged than the classical angina. It occurs more women under age of 50, as I mentioned before. Long-term prognosis is very good one. The majority of the patients have an atherosclerotic plaque, however. The therapy of this pre-spinal angina, calcium channel blockers, it can be effective in more than 70% of the patient when they reduces the vasospasm and increase the oxygen delivery to the tissues. Acute coronary syndrome. Basically, acute coronary syndrome that characterized by the common pathophysiology of the disrupted atherosclerotic plaque mainly means that the doctors have to do immediately something to prevent the development of necrosis of the patient, of the myocardium. When the patient does have the discomfort, or let's see the sign of ischemia as an anginic pain, they are going to take an ECG and withdrawing some blood for biomarkers. Based on the ECG findings, there are two different categories can happen. Let's see first when we do have the characteristic changes such as the ST elevation. If we do have a very big, very informative ST elevation, immediately the patient can be sent to the coronary unit where they can perform angioplasty or can dilate the coronary or implant a stent, and this is how they are going to prevent the development of necrosis. However, when we are not certain whether this ST elevation can be behind of these clinical symptoms or features, the troponin level is be informative. And when troponin level is high, very similarly, go to the coronary unit and implant the stent or perform the dilation of the coronary. Another, when the ECG does not have any kind of symptoms, there is no ST elevation, maximum we do have an ST depression or T inversion, so the sign is not supporting the diagnosis of myocardial infarction. This is when we have to rely on the troponin level. If the troponin level is elevated, now this kind of patient is called a non-ST elevated myocardial infarction, and they have to treat it the same way as the STEMI, so they have to put stems, they have to send to the coronary unit. When the troponin level is normal, we have to assume that this patient had unstable angina and further evaluation is needed to prevent another accident that happening later on. If the doctors cannot reperfuse the heart in time, Q-wave MI or non-Q MI can develop in this patient when represented by basically necrotic tissue.